Welcome to NCLEX in practice. Today, we're going to look at disseminated intravascular coagulation, or DIC, and why it is one of the most confusing emergencies you will see on the NCLEX. Here is the paradox. A patient is bleeding and clotting at the same time. Both problems are caused by the same disease. Picture a postpartum patient. She is oozing from her IV site. Bruising is spreading across her abdomen, and dangerous clots are forming inside her blood vessels all at once. That is DIC. The body activates its clotting system so aggressively that it burns through all available clotting factors. The result is uncontrolled bleeding in some areas and dangerous clots in others simultaneously. Now, your first scenario. A nurse is caring for a postpartum patient with confirmed DIC. The patient has active bleeding from multiple sites, and lab results show critically low fibrinogen levels and a prolonged clotting time. What should the nurse do first? Option A, prepare to administer fresh frozen plasma as prescribed. Option B, apply firm pressure to all bleeding sites and monitor. Option C, administer a heparin infusion to prevent further clotting. Option D, treat the underlying obstetric cause by notifying the provider immediately and preparing for intervention. Let's work through this. Option A is not the first action. Fresh frozen plasma replaces clotting factors and may absolutely be used, but replacing factors before addressing the cause is like refilling a bucket that still has a hole in it. Option B is incomplete. Pressure helps locally, but DIC is a systemic problem. Surface pressure does not stop internal clotting or fix the underlying trigger. Option C is dangerous here. Heparin is sometimes used in chronic DIC to stop clotting, but in an acute postpartum case with active bleeding, giving an anticoagulant can be catastrophically wrong. Phase matters. The correct answer is option D. On the NCLEX, DIC always requires treating the underlying cause first. The trigger is what keeps the clotting cascade going. Until the trigger is removed, no amount of blood products or medication will stabilize the patient. Notifying the provider and preparing for intervention directly addresses the source. Now your second scenario. A patient with sepsis develops DIC. Bleeding has slowed, but the care team is concerned about organ damage from microclots forming in small blood vessels. What is the priority nursing action? Option A, increase IV fluid rate to flush the clots. Option B, continue treating the underlying sepsis aggressively as the primary intervention. Option C, hold all anticoagulants until bleeding resumes. Option D, reposition the patient every 2 hours to improve circulation. Option A is incorrect. Fluids support perfusion but do not dissolve microclots and are not the priority intervention here. Option C is incorrect. Holding anticoagulants based on bleeding alone ignores the clotting side of DIC, which is causing organ damage right now. Option D supports comfort and skin integrity, but does not address the life-threatening process happening inside the vessels. The correct answer is option B. Treating the underlying cause is always the anchor intervention in DIC. Whether the patient is bleeding or clotting, the cascade will not stop until the trigger does. Sepsis is the trigger here, and aggressive treatment of the infection is what gives the body a chance to reset. The key takeaway is this. DIC is a two-sided emergency, and the NCLEX will test whether you understand that the phase of DIC changes, which interventions are appropriate. But treating the underlying cause is always the first and most important priority, no matter what phase the patient is in. See you next time on NCLEX in practice.